Welcome. I'm Carol Jenkins, Executive Director of Cystic Fibrosis Research Incorporated, or CFRI. This CF Discovery Series was developed in collaboration with Camille Wasowich, nurse practitioner at Stanford CF Adult Clinic. It was designed to make vital CF information accessible to the CF community. Before beginning, I'd like to note that no information presented tonight is intended for a patient's diagnosis or treatment. As always, we urge you to work together with your healthcare team for medical treatment. Tonight, we're looking forward to our presentation on CF ABPA. Thanks to Genentech for supporting this important evening. Their support pays for the venue and refreshments and the studio we've constructed here and other costs associated with the program. Tonight's event is being produced by your CFRI Live team, Eric Martin, Scott Wakefield, David Suhu, and Joanne Davis, who is tracking questions online from our participants. We are live at the Crown Plaza Cabana Hotel in Palo Alto, and I encourage you all to ask questions, whether you're here in the audience or part of our online community. And hello especially to those of us who are in the hospital. We're so glad that you can join us in our streaming broadcast. Finally, thanks to our volunteers for serving food and helping with our cross-infection guidelines. Tonight, our speaker is Dr. Rick Moss, who has spent much of his distinguished career helping patients and families with cystic fibrosis and conducting CF research. In 1977, he completed his residency at Northwestern University in Illinois and then completed his graduate medical education at Stanford University Medical Center in 1981. His clinical focus has been respiratory specialties at the Stanford Clinics and at the Lucile Packard Children's Hospital. Dr. Moss served as director of the Cystic Fibrosis Center at Stanford University from 1991 to 2009. He also served as director of the Allergy Immunology Fellowship Training Program at Stanford from 2006 to 2011 and continues to be a member of the Stanford IRB, also serves on the executive committee of Spectrum Child Health. Dr. Moss is Professor Emeritus in Pediatrics Pulmonary Medicine and also on the Emeritus faculty of Medical Center Line in Pediatrics Pulmonary Medicine. Dr. Moss has been recognized with many awards in his distinguished career, including Best Doctors in America, 2001 and on, America's Top Pediatricians in Pulmonology by the Consumers Research Council of America in 2002, and I wanted to note he received the Professional of the Year award from CFRI, and that is us, in the year 2003. Dr. Moss continues his basic and clinical research with a focus on the pathogenesis of chronic airway diseases of childhood. Please help me welcome Dr. Rick Moss.
Thank you, Carol, for that very generous introduction. Let me see about getting this here. There we go. Okay. I'm going to talk about ABPA, which is an abbreviation for this longish title, Allergic Bronchopulmonary Aspergillosis, but also put it in context of another problem in general in CF, which is fungal infection. We're used to talking about bacteria, but as I will show you, I think fungal infections have also begun to be more of a problem. Aspergillus is a mold, and it lives really in two forms. One is a growing form, and one's a sort of dormant form. And what you see here in this picture is the growing form producing the dormant form. These are spores or little particles that basically are reproductive pods. And you can see that each individual Aspergillus mold can produce a lot of these, in fact, tens of thousands. And these little spores are very easy to aerosolize. They go up into the air. They're of a size which we can breathe in. So some spores are not like that. And these size spores are capable of going way down into the airways, and that's one of the problems. The other thing that's kind of unique about this, and may explain why it's so important, is that this particular mold likes to grow at body temperature, human body temperature. It has a range of temperatures that it's comfortable with, but it seems to be ideal at body temperature. So it may have some advantages in terms of growing in a human host if that host is capable of supporting it. So one of the ways it grows is in mucus, and what you can see here is a enlarged photomicrograph of a mucus specimen that's been stained for mold. And you can see here that these growing sort of branched objects are the hyphae, or the filaments of the growth phase of Aspergillus in the sputum. Now, normally you don't see this. In normal people who don't have any respiratory problems, we constantly breathe in these spores, but we get rid of them immediately, and you don't get this kind of germination. This situation really occurs only in a few problems clinically, and CF is one of them. The other major problem is asthma, and especially that's not well controlled. Aspergillus is one of thousands of different families of molds, and in fact there are about 100 different species of Aspergillus. I'll be focusing primarily on one species called Aspergillus fumigatus, which is the most common problem. But if you look at this picture here, you can see that this is a fungus that can cause a lot of different kinds of disease. Other physicians who deal with people that are immune compromised, including lung transplant physicians, and patients are familiar with the fact that this can be a deadly, invasive kind of infection where it escapes from, usually starting in the lungs and goes into the bloodstream, and then can go to other organs. A very high mortality rate, very difficult to treat. I'm not going to be really talking about that, but it is relevant to CF in terms of the transplant world. The other two situations are more relevant to patients with CF before transplant. Some people that have underlying lung damage can develop Aspergillus infection. And in other people who are immunocompetent, that is, they don't have any defects in immunity, they can get an allergic situation. So what I'm going to mention tonight is basically two of these possibilities, although others also occur. These are the main ones. And one is a form of infection that's been recently recognized called Aspergillus bronchitis. Again, we're used to thinking of bronchitis as being caused primarily by bacteria, but now it's becoming clear that in certain people, molds, and most prominently Aspergillus, can cause a bronchitis also with chronic productive cough and obstructive airways disease. The other aspect is ABPA, which is one of a spectrum of allergic phenomenon due to the reaction of a person against this fungus. So if you look at this spectrum of disease and relate it to the host immune competence, you get this spectrum starting with the immune deficiencies on this side and going to the immune competencies on this side. And in CF, we're really dealing with this end of the spectrum. So primarily ABPA, but also in patients with pre-existing bronchiectasis, the possibility of bronchitis and occasionally other complications due to infection. Well, when we do sputum cultures, it's been noticed for many years that Aspergillus sometimes pops up. And recently this has been studied a little more rigorously. And what you see here is a study from two centers in France recently published, which showed, I like it because it shows the prevalence or the occurrence of Aspergillus and other molds, but does it in two ways. One is what's called a cross-sectional, or the translation they use is transversal, so one point in time. And another piece of the study is longitudinal, so over a period of time. And what you see here is that Aspergillus is recovered in about 1 out of every 5 cultures on a cross-sectional basis. That is, if you took 100 people and just took one sample from them. But over time, it becomes more prevalent, so that if you miss it on one occasion, you may find it on another occasion. So that's one thing. The second thing is to notice that it is by far the most common. These are the top 3 recovered fungi in CF patients in this study as well as most other studies. And you can see that Aspergillus fumigatus dwarfs the runner-up, which is called Pseudosporium. and other forms of Aspergillus, other species. So it's by far and away the most common problem. And we become aware of the fact that over the past 10 to 15 years in particular, when this has been looked at a little more carefully, that the recovery of Aspergillus is becoming more and more of a problem. So this is information from the CFF registry, which, as you know, tracks a lot of clinical data for over 25,000 of the 30,000 or so patients in the United States. And you can see over the decade from 1995 to 2005 that there was essentially a doubling in the rate of Aspergillus. And there's no indication that this is tapering off in the subsequent years either. Is this just unique to the United States? Well, no. There are a number of studies from around the world. I'll show you just a couple. This is one from the United Kingdom, and this is kind of a mini CF registry in the sense that there are far fewer patients in the UK than in America, but they have a very similar actual recovery of Aspergillus to the 12% noted around 2005. This is from 2003 in the UK. So, again, it's one of the major players. We're used to thinking of these bacteria as the big problems, but when you recover something this frequently, then it's liable to become a big clinical problem also. As if that isn't bad enough, we're now learning the fact that our cultures are really problematic. And that's illustrated in this particular study that was recently done in England. And what you see here are a number of different categories of people. ABPA is here on the left. This is a group of people with chronic pulmonary aspergillosis, chronic lung infection. These are usually people that have some pre-existing structural lung problem. The third column here stands for invasive aspergillosis. These are the immunosuppressed people. And then these are healthy people here. And what the researchers here are doing are comparing culture positivity rates versus a non-culture technique called PCR, which is a molecular method that's much more sensitive. And you can see in comparing the ABPA group that in the patients they looked at, they didn't recover any positive cultures in these 19 patients, but 15 of them actually had evidence of Aspergillus in their lungs when they used the PCR method. So it's likely that our cultures, even when they're done very well and frequently, are underestimating how common this problem is. I think that it's present in most, if not all, patients, at least occasionally. If you look through a list of all the different studies that have been done, this is a very busy slide, but the take-home message is really that averaging out over results from various places, including Europe, the United States, and Australia, you get the feeling that we're talking about 25 to 50% of patients will have Aspergillus cultured from their sputum. And as I say, that's probably an underestimate using newer techniques than the conventional cultures. And ABPA is also somewhat variable, but again, a worldwide survey would show about 10% of patients across the board will have ABPA. So it's a common problem. This is another study, this time from Australia. So now we've looked at the United States, Europe, and now looking at Australia. And again, we see that as we go from 1998 to early 2000s, there's an increase in the prevalence of both recovery of Aspergillus and also, alarmingly, the increase in ABPA. Now, part of the picture in ABPA is complicated by the fact that the diagnosis is difficult, but it probably is also a real increase. How do you get this in your lungs? Well, it turns out that Aspergillus is one of the most common molds in the environment, and it's present both outdoors and indoors. The house doesn't need to look this bad to be growing Aspergillus. This is a survey that was done in Iran, of all places, in Tehran. And what they did was compare the recovery of a number of different Aspergillus species, both indoors and outdoors, through different sampling techniques. And you can see here that outdoor recovery of Aspergillus fumigatus in particular is higher, but a very substantial proportion of the homes were also positive. And these were the homes of kids with asthma in Tehran, so they targeted that group to look at the exposures. But there's lots of data like this from various places around the world. So we know that we're constantly breathing in these spores, and there are environmental spikes of this at certain times, both indoors and outdoors. If you have water damage in the home, it's much more likely that you'll recover the aspergillus, whether or not you have these really bad areas visible. Another way that we know we're getting exposed to it is in dust, which is kind of interesting. In allergy, we used to think that house dust was primarily a problem because of this critter here, this house dust mite, which is basically a microscopic little organism that people get sensitized to. But this particular picture shows house dust mites surrounded by aspergillus spores in that sample. And what you see here are measurements of a major allergen inside Aspergillus fumigatus, and you can see that it's positive as well as it is in outdoor samples. This is a leaf extract, but the interesting thing about house dust is when they cultured the house dust, the levels went up. So the spores that were present in the house dust can germinate and create more of the allergen. So house dust control measures probably do have a role in remediation of exposure, but they're overwhelmed by the outdoor exposures that we all have, especially if we are in certain environments such as rural areas, exposure to hay piles or organic compost, things like that, which are especially high in these aspergillus spores. So what are the risk factors for actually getting chronic infection, colonization, or a chronic infection in patients with CF? Well, there have been a few the literature on this is pretty recent, as you can see here, and I want to just point out three different studies that were done in this area. This first one here was from Johns Hopkins, and what they did was look at the decade from 97 to 2007. And what they noticed was that they recovered aspergillus in only 2% of their cultures in 1997, but 28% in 2007. So were they getting better at cultures, doing more of them, looking harder? It's hard to say, but it's probably also a real temporal increase. They were more common in older people with CF than in kids. There were treatment factors associated with higher rates of recovery, including the use of antibiotics, and I'll come back to that in a minute. And also the severity. So as one's lung function declined, it was more likely that you would find it. Surprisingly, people that were taking inhaled steroids actually had less recovery than those that were not taking inhaled steroids, and this sort of runs counter to what we thought we'd find because there's this idea that steroids make you more susceptible to infection. It's actually not the case, at least in this study. These second two studies both come from different centers in France, and the only association found in this one was that not aspergillus but Cedosporium was associated with the occurrence of ABPA. And in the other study, which was several centers, another somewhat surprising finding that poor nutrition was associated with more ABPA, and the long-term use of azithromycin or Zithromax was associated with more colonization. So there's a hint that our use of antibiotics for various purposes in CF may be selecting out more fungal problems, and that seems to be backed up by this study from Ireland, published in '99. If you scan through what they did was break their patients into those with aspergillus or did not know aspergillus in their cultures. And in the positive group, they found a higher rate of the use of oral antibiotics and also a higher rate of the use of inhaled antibiotics, as well as the combination. So there's probably a real association between more use of antibiotics, which are very effective in helping our patients, fight off their bacterial problems, and increasing rates of aspergillus colonization and perhaps infection. So there's always a price to pay in allopathic medicine, and this seems to be one of them. And this also was apparent in the studies that led to the licensing of Toby, which occurred in the late 90s. What you see here is the Toby group. This was about 500 patients that were in this phase 3 trial that led to the licensing of Toby. And there was a placebo group treated for 6 months with placebo versus patients that received the active formulation, And there was an increased recovery of aspergillus in those that were treated. And then there was an extension study that followed these patients for another 18 months, and the rates seemed to go up over time. So that was an early indication that inhaled antibiotics as well as oral antibiotics might be a problem, at least in terms of recovery of aspergillus. So one of the things that comes up with this is, if you have aspergillus in your sputum culture, is that a problem in and of itself? And this was an unsettled question, and I would say still is a controversial question, but there's at least some concern. And one of them is this study that was from the Hospital for Sick Kids in Toronto. I know Dr. Ratchin will be down here for the annual conference, and maybe you can ask him about this, but one of the many studies that they did there was to look at this question. So what we have here is a database which is excellent and goes back many, many years, so they can track their patients very well. And what they see here is that in patients that have recovery of aspergillus but not Pseudomonas, they actually had worse lung function at any given time than patients that had Pseudomonas recovered. Now, we're used to thinking about Pseudomonas as a very big problem, but in this study, aspergillus was even worse. And when you combine patients who are aspergillus positive and also Pseudomonas positive, they had the worst track record of all in terms of their lung function over time. So this is what's called epidemiologic data. It shows associations. It doesn't prove one thing causes another, but it's a worrisome association, and people are now at least sensitive to the idea that having aspergillus per se might be a problem, and there's now studies coming out that seem to beef that up in terms of inflammation associated with aspergillus in the airways. Now, aspergillus is not the most common cause of allergy in terms of molds. But it's very important in CF. So I want to make a distinction between CF and not CF. This slide here is showing a national CDC study that's done periodically here in the United States called the NHANES. And they publish stuff every few years from this ongoing study. They focus on different medical questions. Recently, they looked at allergies and asthma. So this is an unselected sample of the United States population of almost 7,400 people greater than 5 years of age. And what they found, if you look through this, is that the number of different things in the environment that are associated with allergies. The most common, for example, is grass pollen, followed closely by dust mite. But if you go down, you'll see here that one mold called Alternaria is responsible for sensitization in almost 9% of the U.S. population. And just below it, we see our friend Aspergillus fumigatus, about 6.5%. And again, these are in healthy people sampled across the United States. So clearly, mold is important. It may not be as important as pollens and animal danders, but it's very important in terms of allergy in general. And aspergillus is the second most common. There is a seasonal characteristic to this. This is information from Europe, Central Europe, and what it shows you is several years' worth of counts of Alternaria, which is the most common cause of fungal allergy. And you can see here that it's basically a summer problem. Because it gets dry, things dry out, and spores are released into the air from things that have dried out plant material and so forth. And so this is something that actually is treatable immunologically. People sometimes get allergy shots for fungal allergy. Comparing CF and asthma, what you see illustrated here is that while Alternaria is the most common sensitizer in people with asthma, it's not very strong in CF if you compare these two areas of this graph here. And just look at the IgE responses, which is the allergic antibody response. So for some reason, which is probably because Alternaria isn't able to grow in CF lungs, we're not seeing a lot of CF allergy in CF patients. We do see allergy to the spores in people with asthma. In contrast, in CF, aspergillus is the problem. So this is information that's typical of the literature. It's from a UK center in Manchester. They have a very important center for study of fungal disease there. And one of the projects they did was to look at this issue of CF, and they found that looking at using skin tests, allergy tests, to look at sensitivity, you can see here that 3/4 of their patients were allergic to Aspergillus, far more than to any other major allergen from the typical group such as grass pollen or cat dander and so forth. So that means that CF patients, A, are very likely to get colonized and possibly infected with Aspergillus, B, that they're very likely to become sensitized, that is to develop an allergic response, and the next thing is that this allergic response, if it gets bad enough, produces this syndrome we call ABPA. ABPA was originally described in people with asthma and later in cystic fibrosis, but both were described a long time ago, in the 50s and 60s. In asthma, patients with asthma who develop bronchiectasis, and initially this was discovered on chest x-rays, but when CT scans came in around 1980 or so, it became clear that bronchiectasis was a feature of this. They were allergic in terms of their skin testing or looking at IgE antibodies. And they also had, and this is a very important piece of it, very high levels of IgE, which is a protein that includes allergic antibodies, but is a more general category of antibodies of this particular type. So they had elevations of IgE that are much higher than one sees in most other situations, and evidence of an immune response in both the IgE, which is the allergic class, and IgG, which is the normal immunity class in the blood. And then they also had higher levels of these white blood cells called eosinophils, which is a characteristic of allergic disease. So it was thought that if you had 5 or more of these things, you probably had this syndrome or disease called ABPA. In turning to cystic fibrosis, it became clear that it wasn't as easy to make that diagnosis. And why is that? Well, as I just showed you, sensitivity to Aspergillus is very high in CF. Probably 60 to 80% of patients are sensitized. CF, by its own definition, is an episodic obstructive airways disease with pulmonary infiltrates and bronchiectasis. So all these things are not peculiar to ABPA. They're actually part of CF. And if you look at people with CF in terms of general allergy, including allergy to molds, the majority are sensitized, the majority are allergic. And as a result, patients have a lot of immune responses to this mold. And in fact, about 1/4 to 1/3 of patients with CF have high IgE, although maybe not as high as one sees it typically in ABPA. So because of these overlap problems, we had a consensus conference that was requested by the CF Foundation back in 2001 and published in 2003 here, and in which we sort of modified the original definition of this problem from its original description in asthma to specifically apply to CF. And one of the key things about it is the association with a deterioration or an exacerbation that doesn't seem to be easily attributed or treatable in the usual way. So for example, you have an exacerbation, you get put on an antibiotic and you don't get better. What is that? Well, it could still be a viral infection, but it could also be ABPA. So a change in clinical status with a high IgE, positive skin test or blood test for allergy, positive test for the IgG response, and then again, a change from baseline in the imaging, whether one does chest x-ray or as preferred now chest CT, that is different from the prior baseline that the patient had. So we're basically putting the situation into the context of the underlying CF to try and tease out which patients have developed this problem. One of the ways that we actually have a leg up on people with asthma is that CF care, as you know, is organized. Most patients are seen in CF centers, and we do things like get our annual evaluations with lab tests, and one of the things that's been added to the bevy of lab tests is, in fact, to look at the IgE level. So starting at about school age, we recommend that patients get annual IgE testing, and if it's high, to then look for ABPA in particular. And even if it doesn't go over a threshold, we would keep looking if we think that it may be a problem. So this is an early warning system that actually is an advantage to the center-based care, because you can pick this up a lot earlier based on changes in the IgE level. There are risk factors that have been found for developing ABPA, which help us to get at the question of why doesn't everybody with CF or why doesn't everybody with asthma get ABPA? And the answer is probably that other genetic factors are involved. So generally being allergic is important. It actually is clear now that if you're a CF carrier, you're more likely to get ABPA if you have asthma. Probably due to the fact that CFTR is involved in defense of the lung against aspergillus, and there are now some publications dealing with that, which are very convincing, actually. And then there are these other aspects of the immune system that are genetically variable in the population, and some of these genetic variants are associated with a higher risk for ABPA. A few may also be protective. And then in CF patients, there's at least one study that has also found that infection with Stenotrophomonas may also be a risk factor, but that's not been corroborated. The next question you might ask is, well, is this really dangerous? Is this something that we need to worry about if we get ABPA? And the answer to that is, yes, we thought so, but this is information that verifies that in a pretty convincing way. This is a study from Switzerland in which they looked at various patients with CF. The control CF are basically those that do not have Pseudomonas or Aspergillus. And you can see that over time they do very well. This is the FEV1 here. This is a smaller airway test. Compared to patients with Pseudomonas infection in the open box, and they don't do as well. They're significantly worse than patients without Pseudomonas. But in the ABPA group, they actually do worse than either group. So especially when you look at their smaller airways, they have more rapid progression of disease. So this backs up a clinical impression that people treating patients have that ABPA is not a good thing to get and needs to be treated. I just want to show a couple of images. I don't know how familiar you are with looking at CAT scans. Hopefully you have had some background in this, but CAT scans tend to be looked at by taking slices across section of the chest. So we're going generally multiple sections from top to bottom sideways. And when you do this, you see these areas where the airways have become sac-like, and that's called bronchiectasis. And typically in ABPA, this bronchiectasis occurs in several lobes around the lungs, and it's generally not restricted to one area. And it also tends to occur towards the center of the lungs in the larger airways rather than further out. If you see this in somebody with asthma, that's definitely not part of asthma. It's a complication, and it indicates that ABPA is a problem. If you see this in CF, you might say, well, this could be CF and it could be ABPA. It doesn't differentiate it by itself. But the other thing that you also see in ABPA, especially in CF, are these very large mucus plugs, which are shown. And some of them are very dense, which shows up as a very white color, which you can see here. So this is actually an area of an airway that's actually filled with a huge amount of mucus, and this mucus is very dense. It shows up this way because it has some metal ions in it. And in fact, and this again is shown here, and it's actually denser than the soft tissue of the chest. If you compare the density here to here, it's actually more intense. So this is called a hyperattenuating, is the term radiologists use. Basically it means very dense mucus plug. And a recent study has shown that if you find these very dense mucus plugs, it not only is consistent with ABPA, it actually is not seen in other conditions, but it also predicts more frequent, more aggressive ABPA, more frequent relapses. So it's a very helpful sign on the CAT scan. The problem here is that it's only present in about 20 or 25% of the cases, so it's not always there as part of the problem. But when it is, it really it's really very specific for ABPA and also is not a good sign to have. In treating ABPA, we have this staging system, which is not a sequence from point A to point B, but it rather represents different manifestations at different times. The diagnosis is usually made here during an acute stage, an exacerbation. Patients are then treated, so another stage would be basically getting better, getting well. And this rarely occurs. In fact, I don't think it ever occurs if there's no treatment, so it's dependent upon treatment. However, after this treatment, most patients will sooner or later relapse. And they won't necessarily go back all the way to looking like the acute stage because they're being followed now and they're known to have the problem. So they may or may not have symptoms, but they have some other aspects which indicate the disease is flaring up. And if this happens and you cannot stop the main treatment, which is steroids, then they become basically steroid dependent. This is more likely to occur in patients with CF who have concomitant asthma. So it doesn't always have to occur, but there are lots of patients that wind up being steroid dependent. And then if there's no treatment in the early days, it was noticed that people would go on to develop scarring and could actually die of lung failure due to ABPA, but we don't see this anymore because they are treated, patients are treated. What does it look like clinically? This is just an illustrated case. It was published because it's fairly rare to see young kids this sick due to this problem. As I mentioned before, it tends to occur later in the course of CF, but it certainly can occur in early to mid-childhood. And this is a case from New Zealand, Australia rather, which shows a patient who was admitted for an exacerbation here, and you can see the decline in lung function. And at the same time, IgE levels are being tracked, and there's this tremendous rise in the IgE level. Patients then treated, and lung function recovers, and the IgE level comes down. So this is a very typical pattern of a very severe loss of lung function, a very big increase in IgE level, and then both things respond with appropriate treatment. And on imaging, it can look like this. So we have a patient that comes in with these very big mucus plugs, or mucoid impaction as it's called, and then after treatment, 2 weeks later, has basically cleared these infiltrates. We got interested in the question of how much of a problem was this in our general population, and in the mid-90s did a study at Lucille Packard where we basically looked at all of our admissions for that year, and you can see the numbers here. Basically, what we did was get IgE levels when the patients were admitted for their exacerbations, and in those days, almost everybody was being admitted to the hospital. These days, quite a few people get home IVs, as you know. But in that era, we were admitting basically all of our patients with significant exacerbations, and about 10% of the patients turned out to have acute ABPA, which we found out by testing those that had IgE levels that were above a certain cutoff level for the full diagnostic criteria. And this was really the only study looking at exacerbations, the role of ABPA in CF exacerbations, until fairly recently when this was also looked at in Dublin. And they took 50 consecutive patients with exacerbations, took a very similar approach, and they found ABPA were responsible or present in 12%, so very similar to the kinds of information that we had. The bottom line here is that if you have CF and you get an exacerbation, ABPA might be the cause rather than a viral infection or a bacterial infection. And it needs to be considered in the evaluation of that exacerbation, because the treatment is different, obviously. Which brings us to treatment. I think I will stop here temporarily. If anyone wants to ask a question or have any points they want to make, I'd be happy to deal with that.
I have a few questions from the online audience.
Okay.
So I have a few questions. One is, would this potentially grow in nebulizer equipment that are associated with treatments?
It can. And again, the usual hygiene that's recommended for nebulizer care should be adequate to prevent mold growth on the nebulizer equipment or the compressor.
Okay, thank you. And the next question is, what is the treatment protocol, meds, and length of time?
That's what I'm getting to right now.
Okay, so we'll wait on
That's
that.
part B here, yeah.
And then there's a point of clarification. If Aspergillus has been found in a CF patient, they still need to meet 4 to 5 other criteria to be diagnosed as ABPA positive patient. Is that correct?
Not only is that correct, but you can make the diagnosis without a positive culture, which is one of the sort of confusing aspects to this. Why is that? Well, cultures, as I showed you, are almost hit or miss in terms of being able to recover the Aspergillus. A lot of cultures are done, they're just regular routine bacterial cultures. Molds don't grow well on those cultures. We usually get fungal cultures as well as bacterial cultures. That increases the yield. But it's also been shown that that is not as good as a non-culture method. And we also notice that the more cultures we get, the more recovery of organisms we get. And we've known this from looking at things like Pseudomonas recovery. If you get 1 culture a year, your rate of recovery is lower than if you get 4 or 6 cultures a year. So part of it is how often you look, and the second thing is what kind of culture media is being used. So you do not need to see a positive culture to make the diagnosis of ABPA.
Thank you.
So, is it on? So I have a question about the Aspergillus bronchitis
Mhm.
versus a typical CF exacerbation.
Right.
So how do you have to go through the course of antibiotics and not improve to know that it's the that it might be like an Aspergillus bronchitis, or how do you differentiate to determine which is which?
Right. So one aspect is the culture is more important. You have to have it in the culture. Secondly, it's more likely if multiple cultures show it than just one culture. Things come and go in CF, but if you keep growing it, then it's more likely to be a true infection. And the third thing is, yes, more symptoms, more problems that are not responding to the usual treatment, which would generally be directed against one of the bacteria. So all those things come into play. And the whole concept of Aspergillus bronchitis is pretty new and is not universally accepted. It needs more study, but there does seem to be some solid evidence. And many people have noticed that when they have a patient that's not doing well, who has a fungus like Aspergillus, but not only Aspergillus, repeatedly grown from their sputum culture, if they're treated with an antifungal and they get better, that's pretty good evidence that it really is a problem. And then the question is, how long do you treat and does it go away? And those are things that need more study. We don't know that. Okay, so I've basically been talking about diagnosis, what is the problem, what's the scope of it, and the diagnosis, and now I'll turn to treatment. So we basically have 3 major ways of treating this right now. And the first one are steroids, and actually steroids traditionally have always been used by mouth, prednisone usually. And the problem, as most people who are involved with CF know with steroids, is there's lots of side effects. And some of these are tolerable and some of them are not tolerable. So an alternative method that's been developed more recently is to use what's called pulse IV steroids. I'll talk a little bit about that. And then that may be helpful for the cases where toxicity is an issue. In the consensus state guidelines for treatment, basically it was stated that steroids are really the mainstay of treatment, and most people would still agree with that. In fact, steroids would probably be used in all patients except those with very bad steroid toxicity. And the way you do this is to start with a lot of steroids, a lot of prednisone. So these are pretty high doses of oral prednisone for the first week or 2. And the patient should then start to improve, and you can then begin after 10 or 14 days to reduce the therapy by switching from everyday treatment to every other day for another 1 or 2 weeks. And then at that point, then you go more slowly to try and taper the patient off within a few months. This is different from the treatment of an asthma exacerbation, where often very few days of treatment is sufficient to really get the asthmatic person out of trouble from an asthma attack. This is a much longer and therefore more troublesome treatment protocol. But this has been used now for over 50 years in various forms and is very effective in treating this problem. If the person then relapses, and I mentioned that most patients do seem to relapse sooner or later, either immediately or after a period of time, then you'd basically go back to square one. But in those patients, we recommend the second tier of treatment, which is antifungal agents, and I'll talk more about that, and then taper the steroids again as the person improves. One of the things that people have long wondered about is, well, do we have to use prednisone? Can we use inhaled steroids? And we know now that, nationally, over half people with CF are on inhaled steroids for a variety of reasons. Unfortunately, the impression that people have had in treating ABPA is that it's not adequate, and that is backed up by some, not a lot, but some information. For example, this is a study recently done in India where adults with a mild form of ABPA were treated with a very high dose of inhaled steroid. This is budesonide is a brand name Pulmicort in the States, and this is a very high dose. And yet, despite this, they did not get good control of their asthma, and their IgE levels did not respond. When they were started on oral steroids, they had a prompt response. So it's very unlikely that relying on inhaled steroids alone will control ABPA, unfortunately. So that leaves us with either using something like prednisone, which has all these toxic side effects, or trying an alternate pathway. And there are just some small recent studies, and these are two of them here, one from the UK and one from Israel, in which patients that were having trouble with prednisone therapy for ABPA were put on what's called pulse therapy with IV steroids. Pulse therapy is something that's been used for a number of years, particularly in serious rheumatologic diseases like lupus or arthritis, other connective tissue diseases. And that's spread to pulmonology to some degree. What we have found is that the use of IV steroids for ABPA can control it without the same kind of toxicity that you get from prednisone. This pulse therapy involves having an IV for 3 days a month. So you get treatment daily for 3 days with a very high dose, and then no steroids for 4 to 6 weeks, and then this is repeated. And this can be done monthly. And in these case series, patients improved and had less side effects than they would have had with prednisone. The downside is it does require coming to a medical facility, having either a temporary IV put in or a PICC line, probably just a temporary IV for those 3 days. And it's expensive. So it's not an ideal solution, but if you're concerned about toxicity, it is certainly an alternative to prednisone therapy. So steroids are still the mainstay of treatment, and everybody recommends using steroids. However, I mentioned also that there are antifungal agents, and in the consensus guidelines from the foundation, we recommend that they be used as an add-on therapy, not as a replacement for steroids, but as an add-on in someone that's relapsed or having trouble with steroids. The nice thing about this form of treatment is that unlike prednisone or pulse steroids, it's actually been looked at in what we consider the gold standard way to do randomized placebo-controlled clinical trials, blinded controlled trials, which show better outcomes. The downside is that these are toxic agents in different ways than steroids, but they have their own toxicities. Number one, and I'll talk about that, there are some important elements of treatment that are difficult in cystic fibrosis. So let's talk a little bit more about the antifungals. The one that people most commonly use is itraconazole, also called Sporanox. And this is, as I mentioned, not the primary treatment, but the next level of treatment in people that are having a slow or poor response to steroids, who relapse, who are steroid dependent or are steroid toxic. So that, when you add up those numbers, that basically gets to almost everybody within a few years of diagnosis. So we use it by giving a certain dose shown here, and then if the dose is more than about 200 milligrams, it's usually divided into a morning dose and an evening dose. The duration of treatment is very controversial. Some people would try and stop it after as little as 3 months. Other people would leave patients on it indefinitely. There's really no good guidance from evidence about which is better. And we have to do certain things for people that are getting any of these antifungal agents. One is to monitor liver function periodically. These drugs, they're called azoles. They're all metabolized, detoxified by the liver, and therefore we know CF has liver involvement, so we have to be careful with these drugs and make sure the liver is handling it okay. If the person is not doing well, lack of response, or if you're concerned about absorption or drug interactions, drug levels are available, and we have a target level where we want to see the drug level maintained. And this turns out to be very important because there's variability between people in how they absorb and metabolize all of these agents. Itraconazole in particular has what's called poor bioavailability. That means even people that are perfectly healthy with no GI disease don't absorb it very well. And usually only about 50% of what you see in the capsule actually gets absorbed into the bloodstream. So in CF it can be a lot less than that because of all the issues with the pancreas and other GI problems. So we know that the variability between people is up to 15-fold, and that really creates a problem. So you cannot predict what the particular response to an individual is going to be, and that's why monitoring of drug levels is important. We can improve the bioavailability of Sporanox or itraconazole by acidifying the stomach. So drinking it with a cola or other acidic drink can be helpful. There is a liquid formulation. It's actually more of an oily kind of suspension that has much better bioavailability as compared to the capsule. So occasionally patients are switched from the capsule to the liquid formulation. The problem with that is, especially if you're an adult or a teenager, it's a lot of liquid and it's not very palatable. There are drug-drug interactions that create a problem, and the most important of these is that if you're taking anything that actually suppresses stomach acidity, any antacid of any kind, including the very popular ones like ranitidine or omeprazole, that's going to create less absorption of Sporanox. So when people are getting both of these, and most CF patients actually do take some kind of acid suppressor, we try and tell the patients to take their Sporanox an hour before they take their suppressor drug. And there are side effects, especially if patients are getting too much, including GI side effects of nausea, vomiting, diarrhea, occasional swelling of tissues, and occasional nerve involvement, peripheral neuropathy it's called, where you get tingling in hands and feet. These are all reversible with discontinuation, but can be troublesome. There was a study from a pharmacist group in, I believe this was in New Zealand, which suggested that adults with CF actually need a lot more Sporanox than most people are using. They had a model in which they predicted the optimal dose would be 500 milligrams twice a day. Very few of our adults are actually taking that much. So again, measurement of drug levels is really important to know that you're in the target zone. Maybe you might need more, and you can certainly increase if necessary, as long as you're monitoring levels. The second antifungal agent that's become more popular in recent years is voriconazole, or Vfend. And this is another relative of itraconazole, as you can tell by the azole end of the name. And the advantage that it has over itraconazole is that it's much better absorbed. The bioavailability is close to 100% rather than 50% or less. So that's the good news about voriconazole, but there's some bad news about it also. And in my opinion, the bad news usually outweighs the good news. So what is the bad news? Well, for one thing is that it's much more complex metabolism. There are actually at least 3 liver enzymes involved in degrading it. And because there's so much genetic variability in these enzymes between people, the variability, instead of 15-fold, is more like 100-fold a difference between people that can exist. So it's wildly unpredictable about what your level is going to be. The other big problem with it there's two others. One is the fact that side effects are much more common with voriconazole. And these usually have to do with the skin being sensitive, especially if you're taking Cipro along with it. But even if not, photosensitivity or easy rash, blistering of the skin is a real problem. And that's definitely an issue. Occasionally, the eyes can become involved with visual disturbances. Luckily, those seem to be reversible. And it actually may inhibit the metabolism of vitamin A, which also goes through the liver, so you can get toxic vitamin A levels if you're taking too much vitamin A, and we all know that we're giving extra vitamin A to people with CF who have pancreatic problems. So these are all issues that can impact voriconazole treatment. The final problem is that it's much more expensive than itraconazole. And so that becomes a strong consideration unless coverage is very good. But it is effective, and this is just one study which shows patients' IgE levels before and after treatment with voriconazole, and it was quite effective in this measurement and also in producing clinical remission or response. So the side effects are listed here. Again, GI side effects are important, visual disturbances, as I mentioned, and the skin problem. And there may be cases where the skin problem especially becomes very bad, and again, as with itraconazole, rare cases of neuropathy. So all these things can crop up as problems and often are related to toxic blood levels. So that's a problem if you're not monitoring levels. There's a brand new antifungal, a relatively new antifungal called posaconazole, and there's really very little information for that available, but it is on the market, and you might hear about that as an alternative to these other two. So those are the azoles, and the real third major area is the use of an immunologic approach with this drug, omalizumab, which is actually a biological agent. It's a monoclonal antibody against IgE. And you remember that IgE is way up in ABPA. So is it way up just because it's a marker, or is it actually involved with the problem? We know that IgE in general is involved with allergic disease, and the way it works is that IgE, which is shown here, binds to a receptor on certain cells in the body. In tissue, these are called mast cells. In blood, they're called basophils. And it's a very strong binding here. And if two of these IgE molecules bound to their receptors recognize an allergen in such a way that they what's called cross-link, or bring these IgE molecules together with their receptors, that triggers the cell to become active. And the cell then pumps out a variety of chemicals, some very quickly and some over a longer period of time, which produce the symptoms of allergy and in the lungs of asthma. So yes, IgE and allergic asthma is a very important part. And as I mentioned, the IgE molecule is binding to the mast cell at a particular spot where the receptor is meeting a particular place on the IgE molecule. This antibody is interesting in that it actually binds to the same place on the IgE molecule that it would like to bind to the receptor on the cell. So it's competing for that same spot. And by doing so, it prevents the IgE from actually latching on to the mast cell. So the reaction won't occur because the IgE molecule is no longer there. It's floating around coupled to omalizumab in the blood, and it's cleaned up by the system in the body that takes care of things floating around that shouldn't be there. So this IgE that normally is triggering this allergic reaction cannot do so because this complex does not bind to the receptor, and the allergen is harmless. It doesn't produce this response. So this has been studied primarily in allergic asthma. Although this molecule has been looked at in other forms of allergic disease, the FDA has approved it for allergic asthma of moderate to severe nature. And in allergic asthma, as I mentioned, it binds the free IgE and therefore reduces the cell-bound IgE. We also know that it actually over time reduces these receptors on the cell. And this is because the production of these receptors is controlled in part by the occupancy with IgE. So if your IgE is taken away, these things will gradually go away, which is also helpful. And that produces a reduction in the allergic chemical release, as I showed you, which then actually clinically we see primarily as a reduction in asthma exacerbations. So this molecule has found FDA approval and is marketed for the treatment of allergic asthma. Now, when we turn to ABPA, the situation is a little more complicated because if the way that this molecule is used is that the dose is determined based on measuring the IgE level in the blood and looking at the size of the person. So as shown here, if you have a very high IgE level to start with, you need more of the anti-IgE to get an effect than if you have a lower IgE level or if you're a smaller individual. So in the way the drug is used, there's an actual graph, or actually table, that predicts the dose that you need to give based on the original IgE level and the weight of the patient. But in all cases, what we're trying to do is reduce the amount of IgE available to a very, very low, almost undetectable level. The problem with ABPA is that these IgE levels are so high. So the doses that you'll normally see for asthma are lower. And therefore, the doses that are used for ABPA are different and generally higher, so up to 600 milligrams of this drug a week may be required. The problem here is that this is an extremely expensive molecule. I mentioned it's a monoclonal antibody, and it can cost thousands of dollars just for a single dose. So you get into a real problem in terms of the economics of this. Nevertheless, in some patients with ABPA, there are now a number of studies and articles which have shown that it can be beneficial. And this is an example from actually one of my patients here who I started on this molecule back in 2005. And this is the situation that led to it. This was a person that was having frequent exacerbations, requiring recurrent treatment with high doses of toxic steroids, and a tremendous decrease in lung function. Once starting that, there was a stabilization of lung function, and IgE levels also improved, and exacerbations basically stopped. And over the subsequent years, this person has done very well. In fact, in the 2 years prior to starting, had a decrease in lung function of 9% a year for the 2 years before starting, and in the 5 years since, actually has gained an average of 6 over that time in FEV1. Now, this is just a single response, but there are now some larger series, particularly from Europe. This is one from Spain, where 18 people with ABPA were treated. Only 2 of these people had CF, the rest were asthma. And the treatment was at least 4 months, but there was a follow-up, and the dose was high enough to be sufficient for these patients. And basically what you see here in the table is that they had a significant improvement in lung function, a significant decrease in exacerbations, and a significant decrease in symptoms, and also a very significant ability to decrease their steroid therapy and even reduce their antifungal therapy, which is very encouraging. Another recently published series from France, again, these are people at different places around France, and they pool the information. 16 adults, none of these had CF, they all had asthma. But again, you see some very encouraging improvement in exacerbations and the need for oral daily steroid dosing with omalizumab. So we're left with a situation now where in very highly selected patients that have a lot of problems with conventional therapy, whether it's steroids or antifungals or both, this is another option that may be helpful. Let me just close by mentioning the fact that although I've been speaking about Aspergillus, and particularly Aspergillus fumigatus, this one species of Aspergillus, there are other causes of this particular type of problem in CF, both other species of Aspergillus. I mentioned Cedosporium before, that's probably the number 2 problem these days, and a series of other organisms that have also been described recently that can cause the same kind of situation. And with regard to infection, again, Aspergillus may not be the only thing that's causing a fungal bronchitis. This is a fairly recently recognized fungus called Exophiala, and now studies primarily from Europe and Germany in particular have noticed that it's been isolated in patients with problems that weren't being helped with antibiotics, who then responded to antifungal agents. So again, I don't think that Aspergillus is going to be the sole cause of either the allergic problem or the infection problem. This is my last slide. Just to summarize, both Aspergillus infection and ABPA at this point I think are important contributors to CF lung disease. ABPA in particular, we know it's there in about 10% of our patients and it makes things worse. So it's important to recognize it and treat it. Part of the way we do that is a high index of suspicion, including screening and other testing when we suspect it, using the criteria for CF modification. Steroids are still the mainstay, but lots and lots of problems, particularly in CF because of other issues that patients are prone to that are worsened by steroids, like bone problems and diabetes in particular. Antifungals are quite effective, but they're not perfect because they have these issues of toxicity and the need to monitor drug levels. And some alternative agents are being explored, and I mentioned pulse steroids in particular and omalizumab. I didn't really touch on inhaled antifungals, but that's another possible option. And then finally, these other fungi seem to be up-and-comers in terms of troublemakers for patients, and we'll just have to see how that pans out. So at this point, I'm done, and I can take questions related to treatment or anything, really, if you want to discuss it more. Thanks.
I've got 4 questions, and just so you know, we have people watching from Australia tonight, and the East Coast and the Northwest, so it's great that
Nobody sleeps, huh?
nobody sleeps, yeah. Taking advantage of a good thing. So some of these may have been answered in part in the last part of your talk, but I'm going to go ahead and go through them anyway, since we don't have our online audience with us right now. So first, both of my kids have Aspergillus in cultures, but not high IgE. What does this mean?
Well, it's very unlikely that they have ABPA if their IgE is not high. It's extremely rare, although not completely unheard of. So I think it's unlikely that that's a problem. But they could have a problem with infection due to the Aspergillus. So it really depends on how they're doing. And if they're stable and doing well, then it's likely that the Aspergillus is not creating a problem. If they're having a lot of clinical problems and they're not doing well with the usual antibiotics that might be treating their staph or Pseudomonas, then they should perhaps think about the possibility that the Aspergillus could be causing an infection. It gets to this whole question of what is colonization and what is infection. And the proof is really in the pudding. If you're not doing well and you respond to a antimicrobial aimed at that particular type of organism, it probably is an infection.
Okay, the next question is, has the treatment of ABPA with Xolair injections become more widespread in CF patients? I think you addressed that a little bit.
Yeah, it is fairly widespread in the sense that almost every center of a certain size may have a patient or two that's getting it. And here at Stanford, we probably have between half a dozen and a dozen patients that are getting it. I have to stress it's off-label, which leads to issues about reimbursement. Now, most patients with CF who have ABPA also have asthma associated with their CF, and it is indicated for asthma, so part of this is playing the insurance game properly. But it is off-label in the sense that there's never been the kind of study of Xolair and ABPA that there certainly has been in asthma. There have been many studies. Asthma is a lot more prevalent. It's very easy to do clinical trials in asthma because there's so many people with asthma. This is much rarer. It's much harder to do clinical trials.
is pulse therapy used with prednisone or in lieu of prednisone?
It's in lieu of prednisone.
Quick one. Is the negative impact on lung function only evident when symptoms are obvious, wheezing, clinical deterioration, or can it be doing silent damage?
Yeah, it's a good question. I think this whole question of the relationship between symptoms and lung function is a general one in CF, and clearly there are people that have decline in lung function that don't feel worse, don't have a marked increase in symptoms. So I think the answer can be, yes, it can be silent. And measuring lung function is one way to obviously track CF. It's the one that sort of is used to find effective new lung drugs for CF. So it's one thing, but it's not the only thing to look at.
Thank you. You just have another thank you from the online audience.
No.
So.
You're welcome. Go to sleep.
One more question.
Yeah.
The relationship between, I know that there's a relationship between hemoptysis and other infections.
Mhm.
Can that same be said for fungal infections and hemoptysis?
I think any very inflamed area of the lung can produce bleeding, and the cause could be, there are a variety of causes. So, yes, I think it could be the case. In generally, hemoptysis is a reflection of a very inflamed part of the lung, and that inflammation could be due to a number of factors, and I think fungal infection could be one.
So if you see a picture of the, you showed those great pictures of what can obviously be called Aspergillus.
Right.
Because they look differently. So if you
Right.
look at those pictures, might that be a way to determine, is it a more bacterial infection versus a fungal infection because of how they look, like on a CT scan?
Right. Yes, so the only thing on a CT scan that really points you firmly in the direction of the Aspergillus problem are these dense mucus impactions, which I said are not present in most patients. So if they're there, it's very important, but if they're not there, you can't say that it's not the fungus. And the appearance of hemoptysis doesn't, it may not show up in a CT at all. So, hemoptysis is something that can occur in many different situations with advanced lung disease or moderate to severe lung disease. But you have to have a lot of inflammation. What we do know is that Aspergillus, and this is very recent information, Aspergillus causes as much inflammation in test tube type studies as Pseudomonas does. So if you take epithelial cells from the lung and you expose them to Aspergillus, CF epithelial cells, they will get just as upset as they do with Pseudomonas if it's Aspergillus. If you do it with some other things like Candida, that doesn't happen. So it is a pro-inflammatory kind of agent in the setting of CF. I don't know if that helped. Okay.
I have another question from the online audience. Once diagnosed with Aspergillus, how often should a patient have their IgE tested?
Yeah, that really depends on where they're at in the staging. So in the acute episode, after the initial test, we usually get one within a week to 3 weeks to see if things are improving. And then after that, it might be every month for 1 or 2 months, and then every other month. And eventually, if the patient is stable, it might go down to as little as the annual test. So it's somewhere in between, depending on where they are in terms of the stage of the ABPA. But it can be frequent in the initial treatment phase, because what you want to see is that IgE level. Let's say a year ago it was 200, and now it's 2,000, tenfold increase, ABPA. Treat the patient, in 2 weeks after that, it might be down to 1,000 or less. And most people are looking for at least a 50 or 60% decrease over a few weeks. So we'll measure it initially fairly quickly after the initial treatment. and then start to do it less frequently, the better the patient is doing.
Wow. On behalf of our group here and our group
There.
that's tuning in, we really want to give Dr. Rick Moss a round of applause. So you've been joining us tonight with the CF Discovery Series. Thanks again to Genentech for their generous sponsorship of this event. They have covered the costs of our studio here and of our refreshments, and we are very much appreciative of that. We have evaluations for you to complete. Appreciate your attention to that. Please join us again next month. We'll be back on Tuesday, April 10th, for a discussion with Dr. Kathleen Cara Fitzpatrick, who will be talking about the who, what, when, and why of eating disorders and how that relates to our patients with CF. In the meantime, drive safely. Have a good evening. Thanks for being here. Thank you. Thank you very much.